Welcome back to another episode of Mind, Your Body, and Soul. I am Joseph Ward, and as always, my man, Mr. Matthias Sweet, is here with me. How you doing, Matthias?
I'm doing all right, Joe. How you doing?
I'm doing good. We back for another great episode. And remember, Mind, Your Body, and Soul is an educational podcast that focuses on all things health related to help our listeners learn more about various health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. And remember, Mind Your Body and Soul is available every Wednesday on our website at www.nmcpodcast.com, as well as Anchor, Breaker, Radio Public, Pocket Cast, Spotify, Google Podcasts, and our home YouTube channel, Neighborhood Medical Center YouTube channel. So make sure you subscribe and like this video, comment, and share, because you're about to learn a lot today. Get your pen and pad out today. You are about to learn a lot. So, Matthias,
Yes, sir.
I like to do stuff a little different. So I have my intro in mind, but let's do a little back and forth. So this gentleman that we have today kind of help us out to get this intro, because we got to make this a good one.
I mean, it's a good one. So we actually met Dr. Alozie a couple of weeks ago at through some drug reps who was talking to us about HIV. As everybody knows, Joe and I specialize in HIV, and we were really intrigued by his information that he gave and what he does. He actually is in the trenches like Joe and I, just like our special guest last night. So we also, we want to bring people to you guys that y'all wouldn't normally have access to. And he's a great doctor. He's a doctor that's working in the field of HIV, internal medicine. I mean, he's in the hospital now, as you can see behind you, steady working. So, like, to me, that's a hero. You know what I'm saying?
Right.
He's like healthcare heroes in the system that's out there living this every day, like Joe and myself. So, I mean, who else to bring you the evidence but for somebody who's living, working, and breathing this whole lifestyle together that we work in today. So we get a great opportunity that nobody else is going to get to see. He's been on CNN. He's been working with COVID. So, I mean, we got a great treat, and it's right here from your little old neighborhood medical center right here in your backyard. So, I mean, I don't know what else to say, Joe.
Hey, look. Innovation. So, Dr. Ogechika Alozie is here with us, and y'all put y'all hands together. How you doing, Dr. Alozie?
How you doing, Dr. Alozie?
I'm here, man. I appreciate it.
He breaking up.
Am I breaking up? Can you guys hear me?
Yeah, you're good. You're good now.
Okay.
We're going to fight with technology. We know how it is. It's all right. We're going to win.
No problem.
Sorry, but welcome. Like, it was definitely a pleasure reading your bio, learning more about you. Like I said, that's why I say innovative. You're thinking outside the box. We're in this age of technology, and you were exposed to information. A light bulb went off in your head, and you like, I want to learn more about this information. And you not only learned more about it, but you found a way to use this information to help improve healthcare. And we definitely appreciate you for all that you brought to the table.
Thank you very much. Yeah, I mean, I think the thing about technology has been one thing that we forget often, right, is that a lot of our clients, right, in HIV specifically, are under the age of 30. And a good proportion of them are between the age of 16 and 25. And so the problem is that the people that run a lot of our organizations are my age and older. I mean, I'm 49 and I feel old. And a lot of the people that run larger HIV organizations are in their 60s and 70s. Right. So they do what they're comfortable with, which is they send letters, they make phone calls. Right. But the kids that walk into clinic these days living with HIV and AIDS, they're sending texts. It's Snapchat, it's TikTok, it's Twitter. And so probably about 8-9 years ago, I started saying, hey, this doesn't make sense in the organization I used to be with. We can't be sending letters to 19-year-olds. We're never going to get a response. Right. And it was amazing to me just how much pushback I got on that idea. We fought and fought and fought. And then finally, we just did it. And I'm kind of like that. I'm that guy that says, well, I know what the rules are, but we got to for our patients. And so we created this text campaign. We used Google Voice, and in under 12 months, we reduced our no-show rate by 65%. We've since gone on to publish that, right, in peer-reviewed journal. And so I think technology is critically important in the world we are today in 2021. It's even more important in our demo of young Black and Hispanic men. And I think that just really is what we have to sort of focus on. We got to find out ways to do this better, because what we know is that has HIV care gotten better in the last 10 years? Absolutely. Yes. Is it as good as it could be? Absolutely not. And if you look tip of Texas to the Atlantic Ocean, that's where the pandemic is. Sorry, guys. I got busted right there. I got a phone call. If you look tip of Texas to the Atlantic Ocean, that's where the pandemic is. It's in young men of color, and we got to treat them better.
Exactly. So, all right. So we already know. Y'all strap your seatbelts on. I'm telling you, make sure you're paying the paddles out. So, Matthias, let's make sure we get some background information. You got that first question. Let's keep this thing.
Dr. Alozie, can you give us some background information about yourself and what inspired you to work in healthcare?
Yeah, so wow, my story is short but long at the same time. So born in Nigeria, moved to Minnesota when I was 4 months old. My parents were students there, the typical Nigerian immigrant dream. Unfortunately for me, my father passed away when I was 4 years old, so it was just me and my mom's. Lived in Minnesota till I was 16. I became a pain in the ass, and so she literally self-deported me back to Nigeria. Sent me back to a boarding school in Nigeria where I went to 11th and 12th grade, went to med school, decided I wanted something different for myself, came back to the States, did a master's in public health and infectious disease epidemiology, the University of Minnesota, then did residency in infectious disease fellowship before moving to Texas. So to answer your second question, why I got into ID, it's kind of funny. That's not what I planned to do. I wanted to be a cardiologist. And so I was doing cardiovascular epidemiology. One summer I didn't have a job and I was kind of bored trying to put things together, you know. And calls me from Nigeria one day and she says, hey, she's crying and she's freaked out that your aunt has HIV. What am I going to do? Do I give her the same cups? Do I give her the same forks? And I'm like, well, what are you talking about? Forks and cups. This is crazy. And that was 2000, and this was 2003. Yeah, 2003.
Right.
And the process of dealing with my mom, trying to help my aunt find medication. Unfortunately, she passed away a couple of years ago from HIV complications. But that process back then just sort of a light bulb went on in me, right? And I was like, wow, this is interesting. And I realized that I was a lot more aligned with public health and global health than I was in cardiology. And don't get me wrong, I got friends that are great cardiologists and they love it, but this is my passion. And ever since then, I've been focused. I went on to become the student president of the Student Health Organization at the University of Minnesota. Throughout the time that I was in Minnesota, I was HIV nonprofits. And when I came to Texas Tech, in 2002 and 2010, actually, I started up their first HIV clinic. And ever since then, it's just been growing and changing and trying to break the rules and break the rules for a good reason. Right? I think when people say, well, why are you always breaking the rules? I'm not breaking them just for shits and giggles. Right. I'm breaking them because it's the patients that are benefiting, right? It's not just a power kick. You got to do it because it makes sense. And so I think that's really the key. And I mean, the rules were written 20 years ago. Even if we look at Ryan White has been great for people living with HIV, but those Ryan White rules were written 20, 30 years ago. So even some of the standards and the HIV AIDS Bureau measures, they're antiquated. They don't keep up with technology. Right. I know we get audited every year alongside our case management organization. And it's always crazy to me, the kind of things that they ding me on, right? Did you do X, Y, Z? I didn't because I shouldn't, right? Or it's in my computer system. How about you learn to use my computer system and then just go look at it, right? Exactly. Why am I getting dinged every year because you don't know how to use a computer and you're computer illiterate? It's 2021, we got to get better people. And outside of, I know this is an answer, but I think COVID is around us. One thing that COVID has shown us is that in a lot of our public health infrastructure, we do not incentivize the right people to go into public health, right? It's sort of that job that you go into because you have a passion, but you kind of coast, right? You're not challenged. You're not forced to get better. And so you look at a lot of public health departments in smaller communities around the country, they're nice people, but they're not great people. They're not people that are trying to change the status quo and improve the public health. They're people that are looking at their cards and you're like, I got to check this off, check this off, check this off. And so we need to do better. And COVID has taught us that. We knew this from HIV a generation ago. We just didn't take those lessons and run with them.
Right. See,
he think like we do.
Yes, but also, like what the thought that's going through my mind. if I'm 10 years old, if I'm 8 years old, I'm a young man, and I see you, and I hear you, and I see what you're doing and what you bring to the table. That's a game changer.
Right.
That's a game changer, because we didn't see a lot of people like ourselves growing up, and
True.
I appreciate your approach and everything, because there's some young men who gonna see you no matter what color they are, but especially young black men. If they see you, that's gonna be a game changer, because I see excellence in front of me. So I appreciate that.
I appreciate it, man. I appreciate it.
So see, so he's like us. He's not scared to say, "I'll just do this and I'll take the hit later."
You got to break the rules.
A lot of times, just to make sure we can bend those rules for the patient, because you got to do what the patient's for. And like you said, times have changed. It's not
Absolutely.
the same thing like back in the day. To tell you to come in, you're gonna come in. Sometimes you got to meet them where they at. Sometimes you got to go to their house. We done met people at the club. We done met people at the barbershop, at the grocery store. Hey, I need to talk to you right now. So it's like that's where you have to go and do that. And you got to be not scared of going and meeting people and being with people.
Exactly.
But that's the way healthcare is changing, because this new generation, Generation Z, X, if you can't talk to them through a text app or through social media, you're not going to get them.
Right. So my question is, you studied medicine in Nigeria, you studied medicine here in America. What are some of the similarities and some of the differences, and especially like studying the field of HIV? What are some of the things that you were able to learn in Nigeria that translated over here in America? But just the experiences, how are they?
I think for me, the biggest thing was that in Nigeria, we didn't have equipment, right? So we didn't have CTs and MRIs and rapid scanners and all these things. So you had to rely on your clinical acumen and your ability to look, touch, and talk, right? So even before I ever talk to somebody, I mean, as they walk in the door, and I do this, unfortunately, sometimes in public, I'll see somebody, I'll meet them a year later and be like, hey, whatever happened to that limp you had? Or remember those black pink shoes you were wearing? They're like, well, how'd you see that? You talked to me for 10 seconds. Because I do a scan. When I walk in, I scan. Right? And so I think that's one of the things that's different here, that the average med student physician in the United States, on average, and there are differences, right? But we're so used to having all these labs and technology around us in the hospital that a lot of times you talk to med students and residents, they haven't even done a history. They haven't had a conversation with the patient and they feel uncomfortable. And so I have no problem. I walk into a room with a wound, with all whatever it is, from chlamydia and secondary infection, I'll sit down right next to the person. And I'm like this, like, what's up? Tell me about your story. Hey, what's going on, right? And I think people always feel it takes so long to do that. You can connect to somebody in under 120 seconds. And that's the reality. If you give them eye contact, if you give them a firm or soft handshake, depending on their hands, right? You don't want to break somebody's hand because you want to be all macho and everything. But if you connect to people and you show them you care, even if it's for a short period of time, they will engage with you differently. Right. And so I think that was, for me, one of the biggest things coming over. I may not have had the acumen from the technology side of healthcare, or the CTs and MRI, but I was definitely going to connect with my patients. And so even in my organization, I always tell my team, and that's the best thing that we can do, is show people that we care. Right. And so I think those are the differences. And the similarities are, everybody reads from the same textbook, right? We all know the stuff. We're all smart enough to do it. I think it's, how do you actualize it? And you guys know this as well as anybody else, that you see clinicians, physicians, NPs, PAs, nurses, and some of them are really nice, but they kind of crappy clinicians because they can't make that connection. And here's the reality. Any robot, any monkey can prescribe HIV medications in 2021. It's not that hard. There's 3 single tablet regimens. They all work equally the same, right? It's just a question of side effects, drug-drug interactions. If you take the damn pill, you're going to get undetectable, right? If you walk in the door, in 100% of HIV organizations in America with new HIV, if you take the pill, you'll be undetectable. The issue is not the pill. The issue is life. Right? It's those social determinants of health. That's the new catchphrase. But I just call it shit that happens. It's life, right? And you got to figure out how to break through people's life. Are they, do they have kids at home that they can't feed. They have rent problems. They have transportation problems. Can't they get to their job? Are they addicted to drugs? Are they incarcerated? Are they in and out of shelter? The things that determine whether somebody's engaged in enhancing care. So that's why you need a team that actually knows how to have those people skills, right? The smartest people in the world are great, but if they don't have people skills, you're not going to change people's behavior.
Yes. Yes. We talk about this all the time because we have a specific way that we go out in the community because we were taught a specific way. And the way we were taught is basically what you're saying. The people are first. At the end of the day, my whole goal is if a person comes in my office and I have to tell that person that they're HIV positive, I want that person to leave my office feeling empowered, even more empowered than when I told you that you were HIV. If I can do that, then I've done my
job. Absolutely.
But I mean, he's reiterating the same thing we preach every day, Joe.
Yeah.
So guys, we two little people on the totem pole saying the same thing that the big guy on the totem pole says. So it gotta be working. We gotta be doing something right. So, but I mean,
absolutely.
When you look at healthcare, you don't see a lot of people who have that real compassion. They get into healthcare because it's a good check or it's a stable job. And it frustrates me and Joe when we go places because sometimes I get fussed at because I don't look at the paperwork or this or that. My job is to get you treated. I get hit on time.
Absolutely.
But it's the point being is my job was I got you in care, I got you treated, got you what you needed. Now let me worry about the rest of the stuff on the back end. And so
exactly
what we need more people to do is figure out how to take care of the patient itself, and not worry about all the other stuff that's stopping us from getting the patient into care.
Right.
That is true. I mean, one of the things that frustrates me all the time, right, is when you get these HRSA reviews. I mean, HRSA is an organization that is built off of 1980s technology. I'm in the state of Texas, right? And our Texas HAB measures, which I can't remember what it's called right now, but it's built on 1970s, 1980s technology, hasn't been updated, doesn't connect to anything, right? And so it's crazy to me that we're talking healthcare technology and all these systems, whether it's Athena, ECW, Carrier, whatever, they're all built to be mobile. They're all built so you can dictate, right? I have a dictaphone right here that I'm doing all my notes on. And then the organization that's the largest HIV organization in the world, really, can't upgrade their technology and can't make interfaces. I mean, it kind of drives me crazy because what happens is that you and I and our teams, we got to do all this paperwork, and it's paper here, there, and everywhere. It's faxes. And it's maddening to me that we're still dealing with this in 2021. I don't get it, but
that goes right into like our next question where it says, can you help us understand what is digital health and how do we use it in healthcare today?
Absolutely. Hold on a second. This is what happens when everybody's trying to call me at the same time. I thought I put this on Do Not Disturb. So for me, digital health is really taking the technology that exists. And people say, well, tell me about that. So, I mean, for example, I got my AirPods in my ear. Right? I'm on an iPhone. If I go to the bank, I don't go to the bank because I can do Wells Fargo and Chase from my phone. If I want something on Amazon, I order it. It's in my house in the next couple of days. If I want to send y'all money, Cash App, Zelle, PayPal, whatever it is, everything we do in our lives can be digital. Right. And we still got those friends that still have a check, right? And they go pay their bills with a check and they go to the shop and they're all right. I'm like, this is crazy. Y'all crazy. Like, well, I don't trust the system. Okay. We always have those paranoid people.
You're right.
They're like my anti-vaxxer friends, right? And it is what it is. They stay in their bubble. But on average, we run our lives off our mobile technology. And so it makes no sense to me why healthcare can't be accelerated, can't be digitized, right? Again, I want my patients to come in, but sometimes it's not convenient to them. And I should be able to have this kind of conversation with my patient and still bill it. Right? My patient should be able to health in our healthcare system. And so my patients that have iPhones, they are able to log in at any point in time and they get their results on their iPhone. And it's encrypted and it's Face ID and everything. I mean, we got to make things easier for people because healthcare is too complicated. Yeah. And I think we're getting better from an electronic medical record standpoint, but the next real place that we got the payment system. And I'm not even talking about Obamacare or not Obamacare. I'm just talking about, listen, if I'm sick and I need to go somewhere, I should be able to go on an app and find out who's going to charge me the least.
Right.
And whose wait times are the best. Right. I mean, because this is the only time in our human existence where you go somewhere without any idea of how much it costs, and then you take a bill and you're mandated to pay it. Right? Even if you go to a restaurant that's expensive and the food is trash, they might count it for you. Right? You don't go to McDonald's and say, I want a Big Mac, and they say, well, that's $2,500. But it's just a Big Mac. And I'm like, yep, $2,500. The equivalent to me is you walk into an ER, they take one thing of blood, they give you one bag of fluid, and your bill's $5,000.
Right.
Mm-hmm.
Right? And they justify that hour of work for the building and the doctor and the nurse. It's just crazy. And we have to find a way to make it transparent. I know the healthcare organizations don't want it to be transparent because that's how they make their billions. But I think that's really where digital health's next sort of frontier is connecting us and then making things transparent.
And see, I agree with you on all that, because I'm kind of, and people gonna kill me when I say this, but oh well. I'm kind of happy for COVID because it pushed us to that next level to where we're able to do the telehealth and do the phone calls. We've been trying to do it for years, but the insurance companies and things weren't on board with it. They're not going to cover this, they're not going to cover that. Then boom, COVID hit, and now anybody can get a telehealth visit. Anybody can get on the app now. So it's starting to change and go that way, which it's sad that it took a pandemic for us to get to the point that we're at.
Right.
And so yeah, I'm just happy about that part. Not COVID, but you know what I'm saying, the technology.
It did force us to use technology, because that's literally why we are here. But I say 50-50 because we had the idea of this podcast before the pandemic, but the pandemic did spur it because we were not able to go out and do our outreach and education like we would normally do. So this has given us a way to merge the two worlds, because we understand that there's a portion of our population, they're not on the in the digital realm. We understand that, but there's a whole population of people who are. So it allows us to reach both populations. So, all right. So, you are one of less than 100 board certified physicians in clinical informatics. So what is clinical informatics and how is it used when providing digital health, or are the two intertwined?
Yeah, I mean, it's kind of a fancy word just to say that I like computers and I like math. I'm a nerd. But I think clinical informatics really is the study of how we use data and clinical data to improve clinical care. I mean, that's as simple as it gets right now. People can talk about Bayes' theorem and how do you connect, but it's a lot of healthcare management. It's a lot of science around data, taking data to improve systems and wrapping it all together. And I think one thing that has happened in healthcare for the longest time is that other people managed healthcare, right? They managed us, they managed physicians, they managed nurses, but they were not clinicians. They were MBAs and MHAs. And so I think what has happened, especially as technology has gotten more and more important, is that physicians that were interested in technology, such as myself, said, hey, wait a second. They want somebody that has a T degree. Right. And this is where I get a little bit cocky and a little bit of swag, but swag is important once in a while. It's like I used to walk into rooms once in a while and my IT guys would get all upset. Why, you're in our business and you don't know what we know. And I was like, hey, one thing in this room, you can't be a doctor for another 8 years. I can learn what you learned in 8 weeks. Right, and that's just the reality. And so pump your brakes a little bit, have some humility, and let's go fix this problem so that it works for everybody. Because the average IT guy comes in and says, well, have you rebooted your computer? Is your mouse working? I mean, they tell you all these things. The average IT group always is the group of no. No, we can't do that. Firewall, security. They hide behind HIPAA and security all the time. But then you ask them to define HIPAA and they don't know what it means. You ask them to actually define what are the rules around PHI. They don't know what it means. All they want to do is create barriers for the improvement of patient care. I think a real clinical informatician is trying to use that technology to improve patient care, to get the patients their information, to get the clinicians the information in front of them so that the note isn't as painful to make, so that you have more time to talk to the patient. And so again, I think complicated sort of word, took a board exam, I had to do some stuff. But the long and short of it is that I'm always looking for ways to break the system to get it better. And so, like, for example, I'm here, I'm connected to this tether on this computer because the head of IT in this hospital that I'm at will not put the mobile app on this computer so I can use my phone, right? And so I can only dictate notes right now where there are these. You would then say, hey, Dr. Alozie, my expectation is that there should be one of these in almost every computer. There's one in every 10 computers, right? So I got to find a specific room and space. Sometimes I got to kick the nurses off that computer, and they're doing busy work too, right? They're busy taking care of these patients. And so it would be so much easier if you just put on all the computers were accessed with my phone. I can't do it. And so those are the kind of things where we try to break. Eventually we try to get rid of people like that. They can go to Best Buy and work at the back room. We need people that are actually dedicated to improvement and patient care.
Yes, yes. Yes, it's when see, I feel like we all like got the same school of thought, because one of the things I was taught when we first started in HIV is wrap your interest around this, and that's what you did with IT.
Absolutely.
Being able to wrap your interest around, and once you do that, it literally opens up like that unlock the creativity in your mind, and you see things other people aren't seeing, you think things other people aren't thinking, but you can bring care to people that people actually really need, not just the care that you think they need.
Right.
Boom.
So with your background and your expertise, you used to be, or you were, the chief medical officer at the Del Sol Medical Center. Why
Yes, sir.
why is the chief medical officer needed, and what are some typical duties of chief medical officer?
So I think the main reason the chief medical officer is needed is to be sort of that liaison, or I call myself a translator between administration, the CEO, CFO, COO, and the medical staff, right? The medical staff is focused on patient care. The C-suite is focused on running the hospital, and they don't get along a lot. There's that clash, right? And so, in a sense, the CMO, in some ways, acts like the sacrificial lamb to both sides, right? I'm able to go talk to my colleagues and say, hey, man, I know you don't like these guys, but hey, here's what we got to do. I'm able to go talk to the C-suite and say, hey, the doctors really need this. And I understand it may be a little bit expensive, but the long-term benefit of this is X, Y, Z. And so that's what the CMO does. I was also in charge of medical staff, getting people credentialed. If there's a problematic clinician in the hospital or physician, going and talk to them and say, hey, if there's any new initiative, like when we had a sepsis campaign, trying to make sure that everybody understood what sepsis was. I was in a unique position as an infectious disease doctor to be able to say, hey, this is my specialty, right? And so if we're going to talk about infections, I can help break it down. And I try as much as possible to take complex thoughts and break them down, right? So people can understand them. And so for me, it was a great ride. I had 18 months of it. COVID kind of changed what I thought about it. When I got there, my initial thought was, hey, I'll do this for 3-4 years, maybe a job in the hospital. Right? I thought that. What COVID showed me is that I have a gift to take care of patients. I have a focus on patient care. I'm a good public speaker. You guys sort of alluded to some of the things I did on TV. I have a weekly Friday gig with a local ABC station now. And my goal is to educate our community in such a way that they're not scared, in such a way that it's not political, in such a way that it's not divisive, right? Get people to that middle. And you're not going to convince everybody. That's just not how life works, right? Anybody that approaches it at, hey, I got to get 100% in people, they've already doomed themselves to fail. And so I think Pareto principles. If I can get 80% ballpark in there, I've done a great job. And so as COVID sort of evolved and I got more and more into it, and you kind of see the underbelly of healthcare too, right? I just realized, man, at the end of the day, I can be the CEO of me. I can do a better job helping my community, my patients, and myself being independent without having a boss. The only boss is God and the time that I have in the day. I guess my wife and children kick in there too. They're the co-VPs, right? But I can just do a better job as me. And so I'm enjoying being back to clinical practice. You guys caught me when I'm rounding. I have like 25 patients to see today. Got here at 6:30. But for me, it's a blessing. I get to walk into the rooms. I get to help patients. I get to go home. I get to flex my schedule based on what my kids need. My son has a basketball tournament this weekend. And so I'll work around his tournament, right? And so you can't do that when you're at a desk or when you're on a corporate timeline. And so I'm happy, I'm blessed. I've had some opportunities when I left the CMO gig to go to Curacao. I was in Curacao for 2 months in the middle of their COVID surge, and I was able to help out there. And that was a blessing too. It's new challenges, new friends, and new experiences. And so I just want to give back, right? And hopefully be happy going forward.
Oh, that's cool.
That's real cool. And I like the fact that, for one, a lot of people don't see doctors like yourself. Because probably I can just see you coming in the room, you're lit up, you're happy, you're excited.
And you can relate.
And you really care. Most doctors coming there with that blank stare, like, hi, that monotone. And it's like, you want me to be happy about something, but you're not excited. And that's what I like to see about like providers like yourself and like the provider we have for like our HIV, Miss Elena Steeple, who's on the podcast. She comes in there and she be like, "Sweet Pea, you did it!" And you know, that person that self-affirmation saying, "Hey, I appreciate you because you might not have that support system at home, or nobody else might think that you quit smoking was a great deal." And you know, with your attitude and your persona, it just changes the whole voice of healthcare. Because if most doctors had a little bit of empathy and show that and that charismatic attitude, it'll go a long way with a lot more of their patients.
Absolutely.
So I have a question that's off the beaten path. It just popped in my head because with the experience in infectious disease, and now we have COVID out, there are a lot of people who have medical mistrust. So how do you personally deal with educating the person and giving them the information they need to be healthy, but at the same time overcoming or combating their medical distrust?
That's hard. I mean, I think the biggest thing for me is patience, right? And again, like I said, I don't approach a conversation in a win-lose fashion, right? This is not war. This is not winner take all. This is a dialogue. And so when people come at me with, well, I don't trust the system, I'm like, okay, well, do you trust me? And a lot of times that catches them because in a sense, I'm part of the system, right? You came to clinic or you came to the hospital. So you trusted something about it, right? And so, and I'm part of that. So if you trust me, then let's go on this journey together. And I tell people, I'm not going to be right 100% of the time, but I'm going to give you the best advice that I know how. Now, you don't have to take it. And some of my colleagues have been upset when I'll tell somebody that doesn't want to get vaccinated with COVID. I'm like, okay, cool. They're like, no, you can't just say that. I said, but they don't want to do it. I can't force them to do it. And so let's allow them to know that it's an option not to take it, but there are risks associated with it. But I'm also, and this is specific to COVID, I've also been really sort of wary of making COVID a black or white 100% issue, right? Because you're in a room with somebody with COVID does not mean you're going to catch COVID.
Exactly.
We know this, right? Everybody that walks in a room with a person that's positive doesn't get positive. You know what I mean? And so there is an HIV, this is really important, HIV, that's about harm reduction. There's no zero risk game in life. There's nothing we do that's zero risk unless you curl into the fetal position, put yourself under a blanket, and lock your door, right? Everything you do has risk. Getting in the car, going swimming, drinking, smoking, whatever the case may be. So if somebody tells me that, hey, I feel more comfortable walking around without a mask in an area that has COVID because I know my chances are only 20 to 30% of catching it and I could die in a car, I mean, that's on them. Now, there are those people that say, well, what about if they give it to me? I say, well, are you vaccinated? Yes. So why do you care? Right? At some point in end game to this is we have all the answers. The answers are all vaccine. Get vaccinated and move on. Because at the end of the day, especially once we get kids vaccinated, then you're going to see the conversation change. Once the kids are vaccinated, there's no more excuses, right? We've gotten 60 to 70% of people vaccinated. If those 30 don't want to get vaccinated and get sick, that's on them. We'll figure them out when they come to the hospital. The rest of us have to move on with their lives, understanding that the vaccine protects us from the terrible consequences. Exactly. Life did not stop in the world because of a cold or body aches or shivers, right? I mean, mama didn't raise no bitch in that sense, right? We can step up beyond that. We are in the situation we're in because people are hospitalized and dying. So if it's just a question of somebody saying, well, what if they give you COVID? And I was like, I'm vaccinated and I had COVID. So I'm vaccinated plus got COVID. My immunity's ready, right? And guess what? For those that say, what about immunocompromised? Absolutely You need to protect them. Adults that are older than 65, those living with HIV and AIDS, those on cancer chemotherapy, let's talk about getting them boosters. Let's talk about treating them a little bit differently. Maybe they need to mask up more often, right? But on average, the part of the population that's vaccinated and relatively healthy, this goes away once kids have access to vaccines.
That's great.
Yeah, and we can't wait for that. And Joe and I already told my boss, whenever we're ready for the booster, I'm ready, because I can't be out there saying we're doing this and we're not vaccinated. We can't tell you, and that's what I don't like about some physicians who don't live that life or don't do that. You're out there telling people to get vaccinated, but you're not vaccinated. Or you're that respiratory therapist smoking, telling me to stop smoking, but you're doing the same thing you're telling me to stop doing, but you're getting people to believe that you know what I'm saying, you need to do this and you live a healthier life, but you're doing the opposite. So it's really good that you talk about that, because I really feel like once we can get these younger kids vaccinated, a lot of it will go away. And with the whole thing is, once we get vaccinated, it won't give the virus a chance to mutate once we can get everybody vaccinated.
Exactly.
Because once it meets with one host that's not vaccinated and goes to another one, it's just like HIV. You take that replication with the RNA and everything, it just mutates and changes to a whole nother beast. And that's why we're at where we're at with gonorrhea being right now, where it's hard to treat. And we got the different things. So it's just like, if people could just learn to vaccinate and do that, and the government's not going to, not even the government, the healthcare professionals are not going to tell you something that's wrong.
That's very true.
Yeah.
And it's not deliberately.
Now we got their kids vaccinated, but they won't get the vaccination. But what's the point in getting your kid?
That doesn't make any sense
your
to me.
kid did it, but you won't do it. And he was like, I still don't trust it, but you trusted enough to give it to your kid. So
you trusted enough to give a child, but you as a grown adult won't do it. I mean, again,
that's special,
sense, right?
That's special. Right. So I'm very curious. The term digital immigrant, and within
you watched my TED talk.
and within the realm of information technology, could you please explain the digital immigrant?
Yeah, absolutely. So I think the term for me comes from the space where you think of people that are natives, right? So somebody in this country is a native, right? Somebody that comes from another country is an immigrant. And the problems you have when you're an immigrant, you come into a new system, you come into a new society, you come into new norms, you got to learn things more. The same way with a digital immigrant, right? These are people that maybe never used a computer. I mean, it's funny. So I grew up in the States. But when I left in 1988, it was the first original Apple, that box, right? Yes. And I was playing Oregon Trail on it, right? 3.5-inch floppy disk that you pop in, right? I went to Nigeria for years. When I came back in 2000, the internet was here. Google was coming of age, AOL, right? Hotmail. And I didn't have access to any of those things in Nigeria. And so even though I had lived here before, right, it was very, very different for me, right? And so getting used to computers, obviously I've gotten used to computers and gone way beyond that, but I had to take a pause one day some years ago and say, hey, just because you are born here or not, you may not understand technology. And so we need to treat people as digital immigrants. Now, the natives are always going to be way ahead. They're going to have like 32,000 devices. They're going to have all the stuff. They're going to know how to hack things. That's fine. But a lot of our healthcare population, especially Medicare, they're older. So they're digital immigrants. We got to treat them differently. We got to make things easier for them. It can't be complicated. It can't be on, I'm looking for paper, there's no paper here, but it can't be on a 12-page thing. And then it always used to drive me crazy that I would go to see my colleagues that are doctors, and every time I'd have to be in that damn waiting room, and you fill out your whole life on 5 pieces of paper. And I'm like, why didn't you send this to me before? You've known for a month that I had an appointment. Why didn't you email this to me? Why don't you have a portal? Right? Why am I wasting my time in this waiting room filling out paperwork that you could have given me 4 weeks before? And oh, by the way, why in God's name do you need my social on every piece of paper? And the same people will be talking to you about digital security. Nothing secure if I have to put my social on a piece of paper. I mean, and I think that's where it's at, because think about this. Think about the amount of trust that we give people every day in hospitals and healthcare systems, because banks don't ask you for your social other than once when you open an account. One person has it, they open your account, they never ask for your social again. Right. You have a username and a password, you have a bank card, it's it. Why can't hospitals do that? Right? One time at registration, never again. Right? And actually, they don't need your social to bill. So why do they need my social? So I've stopped giving people my social probably about 5 or 6 years ago. I will not give you my social security number unless you show me a reason why you need it, especially if I have insurance, because then my insurance information that you need, and you don't need my social. So I think that whole digital immigrant thing for me was really helping people to need to be on their terms, but at the same time enabling them to engage with the system, so it's just more advanced and more efficient.
It makes sense though. It makes, the way you explain it definitely makes sense, because you're new to this space.
Exactly.
we were digital immigrants just coming up in low income communities, because we really didn't utilize the internet until maybe 2007.
Yeah.
And you know, we had chat rooms. You know, when MySpace and YouTube came out and Google, that's when we really started using the internet. But it's really like as a tool in 2007.
Yeah.
Because think about it, how we got anywhere in big cities. Like I tell everybody every time when I travel back and forth to Atlanta, how did I get around without GPS?
MapQuest, baby.
There you go.
That's what I was
to say.
And it was like you had to know what you had to plan out
them
where you were going and had your list and your instructions. So it wasn't well, that restaurant's closed, let's go somewhere else. Because you had to get back on MapQuest and go to a computer and print it out. Because we ain't had no smartphone. So now it's like, take me to Longhorn. Boom. Which one do you want to go to?
Yeah.
And you know what I'm saying? So we look at like how our lives have changed. Because like you said before, we ain't had that. We were so excited when we got on the computer and say, you got me. Got something, or you on the AOL. Guess what? You couldn't even get on because what? Your mama on the house phone. The same thing. So it's just like
definitely came a long way.
We came a long way to with the things that we doing. So I mean, the whole thing makes sense. Now I'm gonna go watch this TED Talk so I can really understand a little bit more in depth about it. But
got to.
It jogs your memory and makes you feel like, because when you hear immigrants, you be like, okay, well, what he talking about? Like, but it's a different type of thing. And actually, anybody could be the immigrant. You know what I'm saying? It's not just about being from the future and not being. It's just that you're lacking whatever the knowledge is that you have.
Yeah.
So in 2016, you were awarded the best doctor in the city of El Paso, Texas. In 2017, you received an award for innovative practices by the El Paso Pharmacy Association. How do you serve patients, and what innovative practices do you incorporate into your practice and help you receive these awards?
So I think the first thing, I mean, at the end of the day, it's God, right? It's God and having a good team. I mean, I've been blessed, health, ability, engagement, and then I have a great team. I have an amazing team in my clinic, and I tell them all the time that all I really do is show up. That they do all the legwork, right? I just show up and see the patients, have a conversation, we go from there. And so I think for us, the year that we won Best Clinic was I just left Texas Tech. I just opened my clinic. We had put a lot of hard work into trying to be good, and our patients just recognized it, right? And so a lot of our patients put us out on blast. They went to social media, they voted, we won that award. It was an award that people vote for, so we were blessed by that. I think the second piece, though, and I've always been aligned with pharmacists, because pharmacists do so much, not only in the hospital, but in the HIV space.
Yes.
The first sort of clinician I hired in my clinic was not a physician, an MP or a PA, it was a clinical pharmacist. Because I realized what Ryan White needed. I realized what it would take for us to get 340B certified. And I realized that she was the best person to do that, right? So she sort of drove that engine with our director of operations to get us the sort of the leeway, that space that we needed. And now we have a nurse practitioner who's amazing as well. And their patients love her. But that alignment with pharmacy, I've been doing it from the hospitals. And so I've enabled pharmacists at every location and institution I've been in to think more, right? Not just to be in the basement checking cards and doing drug interactions, but to come out, come talk to the patient, round with me, learn how I think, learn how the other physicians think, help the physicians help themselves by not making those mistakes and dosing errors, help the patient get the medication when they're about to go home so they don't have to call back 2 days later, right? I mean, those are all the things that they can add to the team, right? I mean, I've had pharmacists that I've trusted enough that I'll be like, hey man, I can't round in this hospital today, go see those patients, and then let's talk about it, right? And then we'll talk and they'll run the program, right? And so I'm super proud to have won that award. I'm super proud that the person that I think was president of the El Paso Pharmacy Association that recently become, I think, a national director of pharmacy for a Tenet system now. I mean, he's doing amazing things, and I hope that I planted a seed in. I hope to continue to plant seeds. I'm all about education. I take on pharmacy students, nurse practitioner students, medical students, residents, just so people get a sense of what good can look like. I don't know if we're great yet. We're always striving for greatness, like LeBron says. But I mean, one thing that I've reached out to the AETCs across the South is if we really want to change the dynamic of HIV in the South, it has to be in the HBCUs. Because you can't talk about us without us. And in as much as there are Black kids, boys and girls in all medical professions across the South, they have just as much, if not more, stigma about sex and HIV than white people do, right? And so it's amazing to me sometimes. I talk to kids and they're like, I don't know, HIV, I can't do that. That's terrible, you know? And I'm like, no, we got to get into those schools now to get the next generation of healthcare providers, technologists, pharmacists, nurses, physicians, whomever, to understand that HIV is a chronic disease. It's associated with stigma. We got to treat people like human beings, just like you do with cancer, just like you do when they deliver babies. And so if we fail at getting that education in now, we have failed, because, I mean, I'm not even 60 and 70, but half of all infectious disease HIV providers will be retired in the next 10 years. Yeah. Right. So we have an imperative to get the next generation trained now, or we would have lost this war, because we will see a return to 80s levels spread potentially when we continue to lose the education of the providers.
Yes. You're talking to two people who I don't have any hair, but the little hair I had at the time, I wanted to just pull it out, because we would go into certain spaces and we're going to give the information. We're going to do our best to make sure we educate people about HIV/AIDS, STDs, prevention of transmission, and they'll bring us in and then say, okay, teach my kids about safe sex, but don't talk about safe sex. Like, well, what you want me to talk about? Changing tires or something? I mean, how are we supposed to do this and this? And like you're saying, getting more people like us, more innovative thinkers, more forward-thinking people, whether you're in HIV/AIDS or not, just more forward-thinking people in these professional spaces. And with us collaborating together, we can help to prevent a second, third wave of HIV happening in the future, because it's one of the things that Matthias and I are worried about right now is so much focus on COVID. People are forgetting about HIV and STDs, and rates have risen. So
absolutely.
So it's about making sure we stay out and utilize the technology that's out there, and going with the traditional ways and the technological ways, and making sure we make a difference and continue to do what we do, because our job isn't going to stop anytime soon.
Oh, hell no.
And then you have people like yourself that are doing that, but like the HBCUs and even the other institutions, people are not going into infectious disease, and I don't understand why. And it's like, it's a passion for me, and I love that, but everybody doesn't have that same passion. Everybody wants to go into, when we talk to the nursing students, oh, I want to go into OBGYN, I want to go into PEDS, I want to do this. Me, I'm not a pediatric person. I love kids, but it's hard for you to communicate what's really going on with kids because it's not really treating the kid. You're treating the parent because the parent's saying this and the kid looking like whatever my mama said.
Very true.
And so it's like that's just hard to really treat kids. So I love kids, but kids are not for me to treat as far as it is a health. But like nobody wants to do infectious disease. It's like a taboo. And even when we go into the schools and we ask the kids, well, how many of y'all parents talk to y'all about sex? Maybe one person out of 30 to 40 in a class will raise their hand. The only thing they say is just don't bring no babies home. And
that's
it. And it's like, well, what else do you talk about? What else do you say? But you're not teaching them how not to bring the babies home.
Right.
And for right now, like this week, I have had almost 10 new clients this week alone to set up appointments. And that is crazy because nobody's doing HIV testing anymore. We're doing these at-home kits. And I don't like the at-home kits.
Yeah, I'm not a fan of it.
You're not going to tell me the information if it's true or not. And then what's going on through your mind? It's a lot more that goes into HIV and infectious disease because that's something you have to counsel because you're getting a diagnosis that you're not really going to be okay with.
Yeah.
So you need those other pieces that fall into hand. But like you said, in about 10 years, I'm real worried because a lot of people don't want the infectious disease.
Absolutely. That is so true.
Some places
it's so true.
In a big city, and it's one clinic, and they have 4,000 or 5,000 patients, and it's one doctor. That's a lot for one person, and
it's impossible. It's not a lot. It's impossible.
Right. And so it's just like, how do we fix this problem? And that's like a question. Like I just don't know.
Just got to keep moving. We got to keep being advocates and using our voice and our information and our platforms because we have to. I believe we have to make sure that we let the next generation know how important and needed they are, but how these fields can be fulfilling and help them meet their goals. So with that being said, our final question. What advice would you give not only patients but providers to help make sure that that patient-provider experience or the overall healthcare experience is the best experience that not only the patient can have, but the provider can have as well?
Wow, that's a hard one. I think at the end of the day, you got to be open, right? You got to be open to change. You got to be open to differing opinions. And you got to approach every visit, every clinical interaction as everyone is different, right? There's no blueprint to it. There's no pattern. And it can't be confrontational. You got to meet people where they are. And I think truly is you got to come into all this with an open mind and an open heart. If you approach your patients with an open mind and an open heart, I think the rest of it sort of goes from there. And then you'll be able to hear them. They'll be able to actually care. And I think if you care and they connect and you connect with them, I think everything else flows from there.
Gotcha. Being open, being him. Well, we talk about it all the time. It's because this is what we do is rewarding work, but it's challenging as well.
Absolutely. Absolutely.
You got to be open.
Absolutely.
So
I'll say one last thing, right? So as much as I'm a technology guy and I believe in technology and it's on my website, I always say that technology is not a substitute for human interaction. No. Right? It will enhance certain things, but at the end of the day, the best part about patient care and clinical care is that one-on-one. Right? And you got to do that first. It's PPT. It's people, process, technology. You got to get the right people, put them in the right team, the right process, then let the technology enhance the other two, right? So PPT, people, process, technology. And so if you get that right, everything else is gravy, man.
There you go. There you go.
It's it.
Right. Write that down, people. Write that down. So somebody see this interview, they like, this doctor bars, just bars, the whole interview just bars everywhere. How do people get in contact with you?
I mean, one of two ways. They can either find me on Twitter at Ogechika. That's my handle on Twitter, or they can go to my website, the clinical website. It's sunsetidcare@gmail.com. sunsetidcare@sunsetidcare.com. I said at gmail.com. That was my email address. And so, yeah, either at Ogechika on Twitter or just go to the website. We got videos there. We got different things. And so if people want to reach out, you can go from there.
All right. Well, Dr. Alozie, this was definitely a pleasure. You took time out of your busy schedule to come and be a part of this podcast. We definitely appreciate you. And we do want to let you know, if there's any way we can help you, please let us know, because we want to be a part of being an assistance to you. So we always ask, how can we help? So please let us know, how can we help? We would definitely like to stay in touch with you and keep some dialogue going, because you give great information, and you're definitely an asset within our medical community, and we appreciate you.
We really do, and we really want to thank you.
I appreciate you guys. Thank you so much.
Yes, sir.
All right, so you guys
not gonna hold you up anymore. Thank you.
Have a great week. Have a great weekend. God bless.
Yes, sir. Thank you.
Thank you.
Take care, guys. Appreciate it. Peace.
Bye.
Yeah. Y'all jealous? Y'all jealous? Yeah. Dr. Alozie. Look.
That was a good interview.
Yeah, he bars. That's all I could say is
bars. I really would bring him back for that's somebody we need to get to come back talk to the nursing students. Somebody to talk to the pharmacists. Somebody to talk to them, because
real.
He real. He out there doing it. He doing
it. It reminded me of the Mr. Leroy days.
Mm-hmm.
That's what that reminded me. That's Dr. Alozie. Yeah, he's definitely a gem. Appreciate him. So everybody, look, this is what we do here on Mind Your Body. So we're gonna make sure that we give you the best information as possible, and go after guests who we know have our communities and the people's interest at best. So remember, he's Matthias Sweet. I am Joseph Ward. This is Mind Your Body and Soul, which is an educational podcast that focuses on all things health related. And we want to help our listeners learn more about the various health topics and information that may or may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Remember, every Wednesday or every other Wednesday, or whenever Wednesday we get this to you, it's on Wednesday. You just be ready. www.nmcpodcast.com. Make sure you check out our parent website at www.neighborhoodmedicalcenter.org. We're also available on Anchor, Radio Public, Pocket Cast, Spotify, Google Podcasts, and of course right here on YouTube. Subscribe, like, comment, share, all those things. And yeah, we'll see y'all next time.
All right.